Hey everybody, welcome back to the Overrun on YouTube. Ed Bowder and Dan Schwester. We're talking about the advancement of medicine. Dr. Devin Dromgoole is with us from Rutgers Health Community Medical Center. Hey Devin, what's going on?
Hey, how are you guys? Glad to be here. Long time listener, first time caller.
And thanks for having us. We've talked plenty off air about having you on the show before, and you're coming fresh off of a presentation of Prehospital Ultrasound and its effects. So I guess to start, I want to hear your thoughts and opinions on this discovery path you've been on for ultrasound prehospitally. As a background, Devin has worked as an EMT and an EMS provider before he went into becoming a physician, before he went into residency. So he's got a really good, interesting kind of outlook on EMS. So as you kind of gravitated more toward ultrasound, tell us about that discovery mission and how you feel it should be used in EMS.
Yeah, absolutely. So my first love for ultrasound started when I started my residency. I had a couple great cases where I caught things on ultrasound that were completely would have been missed otherwise. And some of them have actually resulted in, major findings that alter patient care. So I had a case that, had a cardiac tamponade that was missed multiple times. And that's one of the things that I actually just recently presented at a conference. So the first time you put ultrasound on somebody and realize that within seconds, you can have high quality clinical images that can change your management, that's a slam dunk from there for me to keep using ultrasound.
And I guess there's always a concern with any new tool that comes out that, it's another thing that we're doing. It's expensive and like that. I don't feel that ultrasound is really a new thing in the field anymore. So if I'm in an organization and I'm actually trying to add ultrasound to our repertoire, obviously the first concern is going to be cost, right? And we hear that there's some projects that are putting ultrasound out on the medic trucks and like that, and certainly they should be, but I guess try and dispel some of those rumors before we really get into the meat of what this is, because I want to be able to show people what ultrasound can do.
So just like any tool, anytime you advance medicine, it's going to come with, you have to get buy-in from your program. There is going to be a cost associated with this to some degree. But when you start to show that there are improved outcomes and then decrease costs conversely by having increased outcomes, if you have a patient who you are differentiating between COPD and CHF, right? And okay, we're going to trial them on BiPAP because we think they have pulmonary edema. You could exclude with just a quick second ultrasound looking at them, right? And that saves you the cost of Lasix. That could save you the cost of the actual BiPAP, unless obviously BiPAP is indicated for COPD. And then when you start to see patient outcomes are improving, especially if you're in a large shop associated with a hospital system, earlier identification of these pathologies in the field is only going to improve outcome. It's going to decrease length of stay. So that's how you can start to try to get buy-in to show that, hey, there is evidence both like in the literature and in what we're actually doing in the field that is improving outcome, decreasing costs.
And there was a talk, I guess, when POCUS first started becoming really popular, and Danny, jump in on this too, where the conversation was sort of like ultrasound is becoming the new stethoscope, which it seemed, it did seem kind of like a platitude when it first came out, right? Because every new thing is the new thing, right? But in your mind, Devin, is that something that we're kind of moving toward? Is this turning into, soon before too long, we're going to have stethoscopes and a probe hanging around our neck? Or where do you think the future of this is going?
I think that is the direction we're heading in. I'm certainly not advocating for getting rid of your stethoscope altogether.
Right.
But what I am advocating for is, if you can listen to someone's lungs and you can appreciate rails, right? Or you can put the probe on and basically see the pulmonary edema with your own eyes, right? You can, as a physician or, advanced practice provider, you can take a listen to somebody's heart and hear a murmur. But if you just put the probe on, you can see that mitral regurgitation in real time. And if you're proficient at it, it really takes almost the same amount of time to do a quick, high quality POCUS scan as it would to do any other aspect of your physical exam. I've now incorporated POCUS pretty much into my primary assessment, particularly for any patient who has any undifferentiated shortness of breath, chest pain, hypotension, altered mental status, because the yield is just way outweighs any expense of wheeling the cart in or having your butterfly turned on or anything like that.
Yeah, it's starting to feel, POCUS is starting to feel like the new ketamine a little bit. Where
remember when that was fun? Yeah,
exactly. We use it for everything and anything. So I do want to show some of these scans here, so we can talk about what we're looking at here on the screen. So This is the site, the POCUS Atlas is what we were referred to. It's a cool website to look through. And here we're looking at, this is a normal parasternal long axis. So talk to us about what we're looking at here in this actual image. For those who haven't seen ultrasound, it might just seem like a bunch of blurry stuff. So and for those viewing, this is a normal parasternal long. There's no abnormalities to look for here. It is colorized by an algorithm that's used on whatever app that was being used. Obviously, the inside of the heart is not green and purple. But so when you're looking at this, Devin, tell us what you're seeing here, and tell us how this can help kind of guide patients' care.
Yeah. So as you said, it is colorized, which is nice. So the right side of the heart is in the green, and the left side of the heart is going to be in the purple color there. So what you're actually seeing is the left ventricle is that large area to the left of the image that's in the purple shading. So this is what's called a parasternal long view. There's 4 views of the conventional cardiac echocardiogram, and they're all taking different slices of the heart. The best way that you can think of ultrasound is it's almost like a flashlight, right? Where you're shining it is where you're going to see. So you actually, when you're looking at the image, the top part of the image is the closest to your probe. The bottom part of the image there is the most far away from your probe. So when you're looking at this, you're actually taking a slice of the heart through the ventricles. And every view has a different thing that it can offer you in terms of diagnostic yield. So the parasternal long, one of the best ways it can be used, especially for a new or beginning user, is to just grossly evaluate left ventricular squeeze. So if you have a patient that you think maybe has some degree of left-sided heart failure, as are most of our patients, you think somebody comes in and they have shortness of breath, you're suspecting maybe it's a heart failure exacerbation. You can pop this on the chest and see that left ventricle is squeezing. So honestly, there are measurements that you can do. There's a thing called EPSS where you can actually empirically measure how well it's contracting. But even short of that, just taking a gross look at it, a normal ejection fraction for your left ventricle is going to be about 65% in most people, give or take a little bit in either direction. So you can look at that yourself and almost think of it. Do you see that chamber there is actually squeezing, for lack of a better term, about 65% of that blood out each time? And you can make an argument that this one is doing that. You can also evaluate the proximal aorta. You can see the valves, and you can see the right side of the heart. In cases of severe right heart strain caused by pulmonary embolism or some other lung obstruction, you can see it elevated here, but this isn't really the best view for that. This is one of the best views for evaluating that squeeze that left side of the heart.
And Danny, looking at this thing, and again, even those uninitiated to ultrasound can see, the left ventricle, they're squeezing every second or so. And this, for our applicability, right? Because it's always nice to say, like, here's a big fancy tool, right? And Dan, in our years, how many big fancy tools come out, every year or two, right?
Love me some gadgets.
Exactly. Like here, here's a new backboard that also will act as a toboggan in the wintertime. So, but here, looking at the LV contraction, I think the most important thing, well, at least one of the most important things, is if I'm a new provider and I'm not sure how ultrasound works, it feels like I can be taught this very quickly. And then, I go out to a cardiac arrest and I'm not sure if it's a PEA or if it's a very slow bradycardia. And this feels like something that can be applied in the field. Dan, how do you feel about kind of deploying this out and making it part of our cardiac arrest arsenal?
I like it. I've always thought that this is something we should be doing. First and foremost, differentiating, is it truly a cardiac arrest where we have to do CPR, or is this a really, really severe shock state? Seeing how the heart's squeezing and whether it's coordinated or not is a really great tool, and this doesn't take a lot of time. I also love the idea of being able to take this picture and physically show it to a physician or even send it to them and be like, hey, check this out. This is something you really need to see. The applications are there, and the prices are going down for these things. They hook up to your phone or tablet. They can take really high quality pictures. You have an internet connection. You can send this to a hospital. You can send it to the receiving physician. I think it's a great idea.
I agree. I mean, I think this could be almost how you transmit EKGs. If you could transmit ultrasound images in real time, and I do think the technology is slowly catching up to where you could start to do things like that through the cloud and other sources like that. and just to kind of go back to what Ed was commenting on about being like a new EMT or a new medic looking at this image and you're like, what am I looking at, right? I equate it to the same thing as when you first get a stethoscope. When you're a brand new EMT student, they put this thing around your neck and you go put it on somebody's heart or you put it on somebody's lungs and you're listening to their lungs and you're like, I don't know what wheezing sounds like. You have to listen to tons of cases of wheezing before you feel confident that I know what wheezing is, I know what rails are. And it's going to be the same thing as this. You're going to have to put it on the chest and you're going to have to look at a ton of normal before you start to understand what abnormal is. And you're going to have to look at a kind of pathology and you get that pattern recognition eventually. So it does catch up. And, you can look at this and just say immediately this is a normal parasternal long axis, but that's because I've looked at hundreds of echoes at this point.
So it's almost like when you get a skill, you have to practice with it to be proficient. That's makes sense.
It's a wild thought.
And there are dozens of feasibility studies out there that show that paramedics are fully capable of doing these, of obtaining high quality images and interpreting them correctly in real time. So, if there's any doubt that like, oh, is this something that EMS can do, not only should do, that has been well dispelled in the literature and in the shops that are actually implementing this in the field.
I could see this being really great for STEMIs too. Getting that abnormal 12 lead and you got the patient with chest pain and you can pop this on and you can see that left ventricle not moving or not doing what it's supposed to do. And it kind of gets your mindset for, hey, we've got a real problem here.
Yeah. I mean, and Dan, as I'm sure we're going to get to in the parasternal short axis, you can actually see the wall motion directly and tell where the STEMI is without even an EKG in some cases. Cool. I'm not saying we don't do EKGs. I'm just saying that it certainly can confirm your finding on EKG.
And certainly the parasternal long, and again, now that we're a little over 10 minutes in, there's a part of me that feels like we can just kind of stop right now and just be like, get an ultrasound, do a parasternal long. That feels like the highest yield, right? Because again, the conversation is, do we teach paramedics this? Do we teach EMTs this? And with any new technology that comes out, I'm always worried that we're throwing away the good in pursuit of the perfect. People that have listened to the show have heard me say that before. And it feels like, we can train, all right, parasternal long, one ultrasound, you can see hypokinetic left ventricle, right? So if someone is just not perfusing the way they should be, you can see if they're in VF, right? If someone is in a PEA and you're not sure if it's actually just a really weak, bradycardic rhythm with a really low systolic ejection fraction, you can see if there's no ventricular wall movement. And, when we talk about what EMS is here to do, those are the things. That's it, right? Everything else is kind of window dressing.
You can see a banged up valve. You can see something like a papillary muscle rupture. You can pick that up because you're going to see that valve flapping in the breeze there.
And you can catch cardiac tamponade. That's a reversible cause of cardiac arrest. That's HNT. That's certainly a cause of undifferentiated dyspnea. You figure in your post-traumatic patients, that's a major finding. You can walk into the trauma center and say, hey, I popped this on this guy's chest. He has evidence of a giant pericardial effusion. I think it's tamponade. Just think. That's a game changer.
I've seen it. It's right there.
Yeah.
It's not this one.
That is a game changer
hey,
for that
doc,
patient.
You're going to want to see this.
Yeah.
And this is also one of those tools. And this is an industry anecdote where I feel like a lot of times 12 leads are captured and sent. And then it's certainly been our experience where you run in and then, the house cardiologist has to see it first, but then also so does the resident EM physician who would very much like to run it past their attending. And so now we're on 12 lead number 6 before we even decide that those elevations are elevations. And this is before we've drawn troponin and, we wonder why door to balloon times aren't going down. But, a tool like this where it's almost you can send it in real time, right? Where I can get on the phone with a provider at the receiving hospital and say, listen, this patient has a hypokinetic left ventricle. It's not like the left ventricle is supposed to beat. Here's a video of it not doing the thing it's supposed to do. And now it's your problem, right? Like
the left ventricle is not left ventricling.
Exactly. Listen, the heart ain't hearting and I need someone to fix it.
I'm not a smart man, but that don't look right.
I don't think we should
what a stopped heart looks like.
I don't think we'd be remiss if we didn't comment that like this is also a little bit of a paradigm shift for EMS. This is the first
Yeah.
time that imaging is available really in the field, except for some isolated like mobile stroke units, things like that. This is the first time EMS has been able to get a clinical image in the field. We've done lab draws, we've done pre-hospital troponins, we've done pre-hospital lactic acids for sepsis, with all of which with questionable yield. However, this is the first time we're actually imaging in the pre-hospital setting. So I think it's a really exciting new area.
It's
And
almost
I just want to jump on one thing too, about the inertia of the industry and the system. All the same things that I hear about pre-hospital ultrasound was the same stuff when I was a brand new medic that they were saying about 12 leads. Like, we need them and we didn't have to do it. And why would you waste time doing that? We're mobile.
right.
We can't be sitting still for this. And it was all bunk. It was all silliness. It's the same thing. I'm hearing it over and over again.
Well, and what's that? That's the 3-step natural progression to understanding, right? First, it's against God, and then it's against nature, and then we knew it all along, right? So getting into the parasternal short, because we mentioned it. So here's another screen cap here. We're going to look at the actual parasternal short axis. So tell us what we're looking at here, Devin.
So you're looking at a slice of the heart basically in this direction right here. So by slicing it down the middle, you're seeing the left ventricle is there in the red, and then they're saying it's green. It's kind of hard to tell on the image, but that other side is going to be the right ventricle, that other like hypoechoic. And that's another word we use in ultrasound to describe things that are dark, or they're hypoechoic. Things that are white are classically called hyperechoic. So what we're looking at here is essentially evaluating the squeeze of the left ventricle. So you can actually see the mitral valve there as well in the blue, which is pretty incredible to say, we can see a valve pre-hospitally.
Right.
So that left ventricle, so this is another good view to evaluate the general squeeze of that ventricle. And again, 65% is supposed to be your ejection fraction in a normal person. You can make an argument that just by looking at this without any training, that's probably squeezing about 65% of the way every time, right?
Right. Yeah.
You can also look at the actual wall of the left ventricle. So let's say somebody has an anterior MI. You could actually see that anterior wall of the left ventricle is hypokinetic and it's not moving very well. There's mnemonics to help you kind of characterize what the walls are on this image, and I'm not going to get into that for now. But if you look at this and you're like, hey, that one little part does not look like it's squeezing like the other parts, and that wall correlates with what you see on EKG, or someone has chest pain, you see that. I mean, that's definitely confirms your suspicion of MI. The other thing you really, go ahead.
Once again, if you know normal, you know abnormal. You might not be able to interpret it, but it's not right.
Yeah. And then the other thing here too is the right side of the heart you want to look at. So this is a really good view for looking for right heart strain. I think EMS in general has very limited diagnostic abilities for pulmonary embolism. One of the best, it's kind of, well, they have chest pain. It might be a PE, but we'll get a CTA at the hospital and we'll find out, or we'll get a D-dimer at the hospital and find out. This view, if you're actually having, like, for example, a saddle pulmonary embolus, where you're actually having now the right heart is pumping against that high pressure, against that high afterload, you will see that the right heart is actually enlarged and it'll be very hypokinetic. So if you actually have acute right heart hypokinesis, that could make an argument that you have right heart strain. And in cases of undifferentiated acute onset shortness of breath chest pain, a lot of the times that's going to be some type of pulmonary embolism or some other blockage. In this case, you don't see that. The right ventricle looks good. You also want to make sure that it's about a 1-to-1 or less ratio, or greater. You want the left ventricle to be 1-to-1 larger or larger than the right ventricle.
And one of the things that I really like about this parasternal short view is, and again, there's, with any technology, right, there's a million fun, sexy things that we can do with it. And again, if you go to the POCUS Atlas here, and we're not sponsored by them, by the way, it's just, this is a good source and we're using them for all of their wares today. So be sure to go and check out their website. It's one of the better ones out there. And just looking at this again, right, without having super in-depth knowledge, you can look at it and you can say, all right, I know I'm looking at a cardiac ultrasound and I know that the ventricle is squeezing, right? All the other stuff kind of beyond that is, again, it's sort of window dressing, right? Where if you can be a rock star paramedic, you can be a rock star EMT, and you can know all of the weird presentations that you can see on ultrasound or that you can hear with a scope, but it doesn't matter if you don't really understand what the big picture of that is. So here, what ultrasound is doing is it's giving us the option to look and see if the organ of interest is actually doing the thing it's supposed to do.
Yeah.
Again, cardiac arrest, low flow states, whether they're bradycardic or they're hypotensive or whatever. And this has applicability in trauma too, which we're going to talk about more in a bit. But I'm worried that is someone having a hemorrhagic type of shock state, or are they taking a beta blocker and that's why their blood pressure is low? I don't really know. I can throw on a parasternal short and I can see the actual squeeze in the ventricle, and I can determine like, okay, well, part of the problem is that there's not enough blood in the chamber for the heart to actually do the thing that it's supposed to do. And I wonder, just real quick, because Devin, I know you've done this plenty of times, for a cardiac arrest, where does ultrasound fall into your algorithm? Because we're going to move on to pulmonary emergencies in a second and then on to trauma. But, in cardiac arrest specifically, it's always so chaotic, especially in the back of an ambulance. There's, however many providers are back there. Ideally, you want it to be, 2 or 3, but oftentimes it's, 4, 5, 6 plus the patient. There might be family, whatever. There's so many things to do in an arrest where I guess to kind of quell the argument of we're already doing so much, why do we add another thing? Where does that fall, I guess, in your arrest algorithm when you're working on patients?
So absolutely, I use ultrasound in every cardiac arrest without fail. It depends on availability of additional personnel. If I'm the only team leader in the room, it might not be the most pertinent for me to be using ultrasound, but maybe you have an intern physician, or you have a medical student, or anybody really helping out. I don't think that ultrasound should ever delay high quality CPR and early defibrillation, as those have been the things that have really been shown to improve outcome, as we know, and you've probably commented on many times in this podcast. So I think there's, people sometimes take ultrasound too far in cardiac arrest, and it's like, wait, I don't have a good image, don't resume compressions yet. So there's actually some protocol out there that says, so most ultrasounds record a clip for maybe 5-6 seconds when you hit the record button for the clip. So what I do in my cardiac arrests is, during a pulse check, a routine pulse check during the code, is I will slap on a subxiphoid view, which we may or may not get to in the podcast, but it's a really great view again as well. Put it on, then pause compressions. The second that we stop compressions, you hit record on that button. Whatever you get in those 6 seconds of that clip, or that 5 seconds of that clip, that's what you get. And then we resume CPR. And that's all you got. And you have the next 2 minutes to review that. Because I've been in codes where people are, putting on the Parasternal long, or they're putting on a subxiphoid view, and it's like, oh, I can't really get a good image. The most important thing is going to be keeping the CPR going. I will say that it is critical for evaluating other H's and T's. So again, if you see that right heart is huge, then that can indicate maybe this person coded from a massive PE, and in which case, okay, maybe we should consider, pushing some type of thrombolytics in the code, or if we get ROSC, we should do early, activate the interventional radiology suite earlier. Same thing, if you see a pericardial effusion and you see that there's complete collapse of the right side of the heart, okay, well, maybe this person coded from a tamponade.
Right.
And then the last thing is also, just once you get ROSC, is how is that heart squeezing now that it's, it is squeezing to some degree, we're getting a pulse. How well is it squeezing? Do I need to up my, my inotropic medications to try and increase that squeeze in this post-arrest period? So this is a subxiphoid view. Sorry, I don't mean to interrupt you.
No, you're fine. You mentioned the subxiphoid view, and again, in an arrest scenario, right? We're talking about parasternal views. The application of the probe is exactly what it sounds like. It's to either side of the sternum, which obviously is a problem in cardiac arrest because that's where everyone is. Yeah. So this subxiphoid view, and again, this is colorized, and again, it's just an algorithm thing that different ultrasound companies offer. But tell us what we're looking at here, because this looks like more of a heart-shaped view than we previously saw. And again, when you're learning ultrasound too, there's orientation that we have to figure out. I know we talked about this a little bit earlier. So if you're new, if you haven't seen ultrasound before, a lot of times things tend to seem upside down. Just because of how we're viewing them. So talk to us about what we're seeing here, Devin.
Yeah. So once again, like we said, it's a flashlight. So the proximal part of the image, or excuse me, the top part of the image is actually the most proximal part of the image as well. And then the distal part is the lower part. So the right side, we're seeing in that red shaded there, you're seeing the left atrium and the left ventricle respectively. And the blue side, you're seeing the right side. This is a pretty normal subxiphoid view. This is also pretty good for, bang for your buck in terms of getting an estimation of squeeze, of right heart strain, looking for pericardial effusion. And this view gives you just a really great overview of just big picture, how is the heart working? This is not going to be the view where you're going to, if you get down to the nitty gritty, you're going to start looking at, oh, well, is it 55% EF or is it 42% EL? Yeah, like this is not that view. This view
I'll
is,
tell you,
okay,
there's already enough math we have to do in the back of the truck. I'm
yeah,
not going to be doing ejection
yeah.
fraction math.
Exactly. This view gives you great, again, you can see it squeezed, both sides are squeezing pretty well. You can see that the left ventricle is at least equal, if not a little bit larger than the right ventricle, which is reassuring. And there's no giant pericardial effusion around it as well. So this is a pretty normal scan here.
It seems to me, and I'm just spitballing here, but you could almost use an ultrasound probe to see how good your compressions are.
So actually, there is a huge push right now to have TEE, so transesophageal echocardiograms during cardiac arrest. At my shop, we're going to be planning to implement it in the near future. So what we've been talking about so far has been TTE, transthoracic echocardiography. So actually looking transthoracic across the chest. Transesophageal is where you actually put a probe through their mouth down the esophagus, and you can actually look at the back of the heart. So there is a lot of push to incorporate this if you have it available during cardiac arrest, because when you're doing chest compressions, we don't really know exactly where we're targeting our compressions to go, right? We're just pushing hard and fast in the center of the chest and the lower 2/3 of the sternum as per AHA. But everyone's heart sits a little bit different. Who's to say that you're not actually compressing the left ventricular outflow tract? What if you're actually compressing the aorta, right?
Mm-hmm.
And now you are doing the exact opposite of what we're trying to do. So if you can actually put that probe in there and have it continuously running on a monitor, for example, or saving periodic clips during cardiac arrest, you can actually see, am I compressing the left ventricle or am I impeding the outflow of the blood? Are we actually doing the right thing in cardiac arrest? I think pre-hospitally doing TEE is a ways away. I think, with EMS physicians, things like that, that's something we can start pushing for.
I can say with TEE, I was involved with some of the original piloting in our state of that. I was lucky enough to ride along and be involved with some of the physicians there. And I can say I think this was like 8 years ago at this point. And we often talk about the glacial pace of progress. And coming into a scene with the TEE with it's a 32-inch television that it's made of all of the heaviest materials that are possibly available to you. And you're also working a cardiac arrest in a, small half bathroom. Right. So I certainly TEE is something I think that is going to come along. What I like about POCUS over TEE for right now is just the immediate applicability, right? Over time, all technology miniaturizes. We all have iPhones. So there's going to be a day where I think that type of technology is going to reduce and we can use that more freely. For now, if you're using a lot of different ultrasound probes that are available, they can plug right into your phone. And that for those wondering, like that's kind of where we are now. That's the reason that we're not moving into TEE immediately, because the in-hospital technology is there. It's just not there for pre-hospital use just yet. Again, it will be. In 10 years, we'll be having the same argument, like, well, how come we haven't been using TEE since the 90s? We'll have whatever the same arguments we always have about everything. But so the applicability for cardiology, obviously, it's very important. It can be used. If the argument is that EMS is there for cardiac arrest, I think the argument has to be made that POCUS is there for EMS, right? If that's the biggest thing we're going to do, great. You have this tool that can show whether or not the heart is moving or how well it's moving. Failing that, there's other uses that we actually have for ultrasound. So if you have a patient who is having a cardiac problem that's leading to a pulmonary problem, then that's something that we want to address as well. So here I'm going to show a normal lung slide. Devin, tell us what we're looking at here. I think cardiac ultrasound is sort of, I don't want to say easy to interpret, but if you're looking at it and you see, the mitral valve kind of flapping, you can kind of be like, all right, that's the heart. Here, I think if we didn't tell you that you're looking at a normal lung, I'm not convinced that anyone will be able to pick up on that. So tell us what we're looking at here and what's good about it before we get into what's the pathological slide.
Yeah, absolutely. So I think lung ultrasound is, like you said, one of those ones where you're like, what am I looking at? Because that does not look like the lung that I saw in textbook or cadaver lab or anything like that, pink, right? Yeah, exactly. I've seen that Pete video with the pig's lungs where they blow it up. This is not that. Exactly. So again, we go back to the flashlight analogy. So this is actually looking down at the lung. And you got to think, if you were looking straight down at a lung, the first thing you'd see in a two-dimensional image, you'd see the skin, you'd see the subcutaneous fat, you'd see muscle, you'd see the ribs themselves. And that's what you're kind of seeing in probably about the top third of that image. You're actually seeing all the musculature, things like that. When you get about halfway down, you'll see that there's again, we use the word hyperechoic, that bright white line that's about halfway through. And that is the actual, yes, there you go. That is the actual start of the lung pleura itself. And then everything below that is lung. Because again, we're basically taking a slice straight down in a two-dimensional image. So that's what you're seeing here. So when you're evaluating, yeah, go ahead.
So, and looking just for, to keep everything in line here, when you're looking at the top is not particularly mobile, right? You know that you're looking down. So we're kind of taking the two-dimensional view. So this top part up here, right? This is all tissue. And you can see this does sort of look like a cross-section of a rib, right? So you can kind of get like, all right, this is sort of the chest wall. So if you're looking at it, then you see the actual tissue moving. That's that pleural lining kind of sliding along the chest the way that it's supposed to be moving.
Exactly right. Yeah. So the fact that is moving is actually a really positive thing. So that's one of the things you're going to look at is that bright white line. I mean, it sounds, yeah.
Top 10.
So like an example. So in an example, if that was not moving, you would say, okay, well, the lung's not moving. So either they're not breathing or they have like a pneumothorax, for example. And that's probably the most common applicability here is going to be, determining if there's a pneumothorax or not in terms of just looking at whether it's moving or not.
Right. And we want to actually see, the goal is to see that the lung is working. And again, like I'm joking, but if you like, oh, there's no lung wall movement. Oh, bad. It's suboptimal.
It's emergency medicine, as you know, is blood's going round and round and round, air's going in and out, and our job is to fix any deviation of those things. So True. Correct. Lung moving, air going in and out. Good job.
So on that same note, though, we can have patients who have congestive heart failure, and they'll show things that are pulmonary edema, and they'll show what are called B lines, and in some literatures they're referred to as curly B lines, which and the worst spelling of curly I've ever seen in my life, by the way. So tell us what we're looking at here, and you can see kind of the subtle differences between that last film and this film.
Yeah, so this is the same type of image where you're looking down at that cross section. But this time you can obviously see there's these bright white hyperechoic lines that are coming vertically instead of they were little horizontal ones last time. These are all vertical. So this is indicative of pulmonary edema. So the actual pathophysiology as to why you get this shimmer artifact with pulmonary edema is pretty complex and is honestly probably a 30-minute discussion in on its own to get through all the physics of it. But the most important thing to recognize,
fluid.
Yeah, give us
that junior year physics lesson.
Oh, traumatized. But the ultimate thing is to recognize this is a pretty advanced case of pulmonary edema. So I actually even call them like UFO beams. They kind of look like they're like sucking you up into space. I don't think anybody else has ever called them that, but that's what they've always looked like to me. But these are B lines. So this person has a pretty significant amount. There's criteria, if you really want to get down to the nitty gritty of, okay, well, how many B lines and how many lung fields means that this person has actual pulmonary edema and not just maybe a little bit of like non-pathologic edema in their lungs. I can tell you in this case, this person is probably a pretty sick patient. That is a ton of B lines. That is diffuse. This person needs BiPAP, nitro, the whole thing, right?
And just so we're clear, like we're using, the clinical terminology of B lines here. B lines in ultrasound in this type of film essentially equates to fluid. It's just like the B line is just the technical term of it, but this film could very easily be called just pulmonary edema, fluid in the lungs. And again, it's that physics thing, right? If you shine a flashlight into a cup of water, the water, it diffracts light.
I was just going to say that. It looks like if you've ever been in a pool underwater or you've ever been in the ocean underwater and it's got sunlight coming down, you get that shimmery kind of light rays. It's the same thing.
Yeah. It's quite a beautiful image, except for what's happening to the patient in it.
Yeah.
Is the irony of it, right? So when you're looking through this, and again, the quick applicability here for EMS, right? we know what that normal lung slide looks like, and you're going to see that, you know, that hypoechoic, that darkened area, right, in the normal lung sliding. You're listening to a patient, they've got adventitious lung sounds, and you're not quite sure, you know, is it rhonchi? Is it really diffuse rales? Like, what are we actually looking for? This is another type of, and quick is a relative term, but it's another kind of quick thing where you can be like, I'm not sure if that's rhonchi or rales. Let me go ahead and pop a probe on and see what I see. So if I had a patient who had, say, pneumonia over pulmonary edema, what would I see on the actual film? And while you're talking about that, I'm going to try and pull it up on here.
Yeah, of course. So you can still see a little bit of B-lines, so there's gonna be still like a little bit of edema probably, but ultimately you can see like some consolidation potentially, especially if you're looking at certain views. So here you can just see that it looks like more grainy, like almost more fuzzy as well.
Yeah.
So you can see that the pleural line is almost interrupted there as well, and there's just kind of these irregular edges to it. You can still argue maybe there's a little bit of a beeline going through there, which seems reasonable. You have some inflammation from the pneumonia locally, but this is more of a case of the pneumonia. What you're looking at, just the way that it's more hazy and more fuzzy, that's going to kind of give that away.
And again, that's a function of pneumonia tends to be kind of phlegmy, really just junky kind of stuff. Pulmonary edema tends to be plasma, so it tends to be very thin and watery like. And Dan, imagine the times, differentiating patients out in the field where it's like, man, I don't know. Is that rales? Is that rhonchi? Do I give nitro? Do I get whatever? And, you run through all the algorithms and then it's like, I think it's probably more of a pneumonia. Let me go ahead and give them albuterol. And that opens them up and they flash, right? So, for years, and this is going back, this is like the 80s kind of stuff where, patients with CHF were getting intubated whether they wanted it or not. And we sort of moved on to CPAP, which has reduced intubations by, exponential numbers across the board. And this feels like, at least to me, it feels like one of those types of technologies where it doesn't necessarily change treatments so much as it can fix destination therapies a lot.
I think it changes treatment. I think you get that patient. Most of our patients have multiple histories, multiple pathologies, and I can tell you, we go once a week to somebody who's got a COPD, CHF history. Maybe they've not been feeling well the last few days, whatever. Am I going bronchodilators and steroids, or am I going nitrates and CPAP? This is going to make a difference for me, because if I see those B-lines, I know it's more of a fluid pathology. If I see the graininess, I'm going to think more pneumonia or, something like that. And if I see pretty much normal lung sliding with that respiratory distress, I'm going to think COPD.
I can't agree with you more, Dan. It is practice changing for me as well. I mean, EMS rolls in, someone's on CPAP. They say it's undifferentiated shortness of breath. I put them on CPAP. The first thing I do is immediately pop it on the chest. And it takes seconds, like right out of the jump. The nurses sometimes hate me because I'm like, excuse me, wheeling in this cart, into the room. They're all trying to get IVs.
Jumping over them, trying to get
excuse me, But it takes a second to just pop it on, look at both sides really quickly. I mean, you can do the full, 8-part lung exam, what have you. You can look at posterior lung fields. You can do all of that if you really want to. But honestly, if you just quickly look here, that'll give you a pretty good diagnostic yield as to whether this is actually CHF, COPD, or something altogether different.
I want to get you like a boom mic stand, just walk into the recess room and just kind of like hang it over like it's a fishing rod.
Well, one of the best things we ever invested in was Bluetooth ultrasound probes. So you can just kind of set it in the corner and you can just kind of do that.
And again, and one of the things that applies too, certainly in hospital, and we're going to talk about trauma now, is, you have someone who comes in with a traumatic injury, and obviously undifferentiated trauma is a nightmare for its own reasons. In the field, we're kind of taught, palpate the abdomen. The abdomen is either soft or it's rigid, done. And I think there's a lot of, I would like to believe the education was done as a form of cognitive offloading, but I know that it wasn't, where it's more, all right, hot belly trauma, soft belly non-trauma. And so here let's do a fast to the right upper quadrant, and then we'll do some right upper quadrant free fluid before we get out of here. So looking at this, right, you come up on the screen here, we've got this normal fast scan. And again, this is the same thing where looking at it without landmarks like that, it just feels like I'm looking at a blob on a screen.
Yeah. I mean, and that's the same argument with EKGs. It looks like a bunch of squiggles until you really are oriented
Yeah.
and know what you're actually evaluating for. If you look at this, so this is a right upper quadrant exam. So actually, I'm going to take a step back for a second. So the FAST exam was actually designed for traumatic cases, for basically undifferentiated hypotension and trauma. And it has 4 cardinal views of the FAST exam. There's an extended FAST exam where you incorporate lung fields, but the core FAST exam is looking at the right upper quadrant, the left upper quadrant. You're looking at the pelvis, and you're actually looking at a subxiphoid view at the heart, as we kind of talked about before. So
Right.
the goal of this is to really identify, is there free fluid in that abdomen, or is there a pericardial effusion from trauma? And those are things that are undoubtedly practice changing. So like you were saying, you have this patient, it's a pedestrian stroke, and they have some abdominal tenderness, but it's not quite peritonitic. Their pressure is soft. If you put it on and you can detect some type of peritoneal free fluid, that's a game changer. They can activate the OR suite of the trauma center from the field if you can send them that image. So this image here in the right upper quadrant, we're actually looking at the top of the screen is going to be the liver, and in the middle there, that round structure is actually going to be the right kidney. So one of the most common places that free fluid will collect in the abdomen, if it is going to collect, especially in a supine patient, is going to be in this area here. So the space that actually sits in between the liver and the kidney, we call that Morrison's pouch. And Morrison's pouch, I don't know who Dr. Morrison was, or if there was a Dr. Morrison, but this was identified as basically one of the big places it's going to collect. And I've seen that many times in my practice, that patients who have blunt trauma, penetrating trauma, particularly blunt trauma to the abdomen, and they're bleeding, you're going to catch it in that right upper quadrant there. So
And
that's what you're looking for.
And again, another thing in traumatic anatomy that I think we teach is we don't teach the voids in specifically abdominal anatomy, where in most of the human body there's blood will kind of stop itself. Once you get into the abdomen, it just kind of bleeds freely, and you can lose most of your volume into the abdomen. So if you have someone who was in a motor vehicle accident, was wearing a lap belt like they're supposed to, maybe they're wearing a little bit high and they've got just like pain in their belly, you can look here and you can see, and just for what we're looking at here, I know we're looking at the right kidney, but fluid is going to show. How would fluid show on here before we get into the pathologic film?
Absolutely. So fluid is always going to look hypoechoic. So that's going to be that black type of collection. The thing to know is that fluid is going to generally follow into like the crevices. So it's not going to have nice rounded borders. You're actually going to see it collecting all the way through. It's going to have sharp angled borders to it. And that's one of the big things you can differentiate, because you might look at that and see a renal cyst, for example, which will have fluid in it and it'll look hypoechoic, but that's going to be like a nice round cystic structure. So as we get into the pathologic slides, you're going to see that it actually collects on these sharp borders in the spaces.
So, and while we're looking at this here, let's go ahead and look at some free fluid here in the actual hemiperitoneum. All right. Share that screen. So we got free fluid here. And again, this is the right upper quadrant. This is the same area we were looking at here. And again, in that last film, and just in lay terms, in the last film that was normal, there was a lot of white. This film, it's abnormal. There's not a lot of movement. I see a lot of black. Tell me what we're looking at.
Yeah, so this is going to be exactly like you said. This is a case of right upper quadrant free fluid. So this patient has fluid collecting in that Morrison's pouch area that we talked about, that has pretty good sensitivity for intraperitoneal free fluid looking in that particular space. So that black part that you're seeing underneath the liver and above the kidney, that kind of almost looks like angled down. So that is going to be fluid. That hypoechoic structure is going to have sharp angles to it. It shouldn't look round or cystic or well-defined borders. It should be just kind of filling whatever void that it's in. So this would be a case of that, without a doubt.
And looking at the film here, if you can track my cursor here, this very acute angle is what Devin is talking about. And what's interesting in what any type of radiology is that because fluid is gravity dependent, it's going to find like all the little nooks and crannies. So fluid is always going to be shown by these kind of hyper demarcated points. And if you're not really sure if it's fluid or if it's, maybe a mass, masses tend to kind of round out, and then there'll be another extra space. So after going through all this, Dan, what are, if I'm putting out an ultrasound probe onto my trucks tomorrow, right?
Yeah.
Talk to me about what views we're looking at. How do you, I guess, try and get it to the staff? And then Devin, I'm going to give you the last word on where you think this is going.
I think it's something to seriously think about. Implementing it is going to be like any other piece of equipment. Competencies, we're going to have to do some practice. I know personally, if I had one, somebody magically dropped a butterfly in my lap, hint, hint, I would be using it on everybody. I'd ultrasound my kids. I'd ultrasound the dog. I'd ultrasound anything just to take a look at normal so that I knew normal, just like I did when I got my stethoscope. I listened to everybody. I listened to everything. And I may not have always known what I was listening to, but I knew it wasn't right. And then you use that experience and we learn from it. And yeah, there's a learning curve. Nothing other than what we've had in the past when we had 12 leads come in, infusion pumps. Think of all the technology that's come in over the last 20 years. We've adapted to it. It's time.
Yeah, I completely agree. I mean, the adage is, what does EMS hate the most? It's the way things have always been and change. you know, um, but I don't think that we should settle for that, right? EMS it just keeps growing and growing. It's still a new service, really, in the grand scheme of medicine and healthcare. And to say that, oh, we've never done this, or oh, it's going to be expensive, that's only going to be at the expense of our patients at the end of the day. And that's what we're all here for, is to just provide high quality patient care. And if you have a tool that you can use that honestly, in the grand scheme of things, is fairly inexpensive compared to the cost of ambulances and monitors and things like that, that is going to radically change a certain subset of patients, your management and their care, I think that we're actually wrong for not utilizing it more.
And I think that's pretty right. Devin Dromgoole from Rutgers CMC, thank you so much for your time and for educating us on all this. You've become a friend of us and for the show over these past couple years, and I want to thank you for that as well. If you get a chance to see Devin touring the country, giving his talks all around, please be sure to do that. And check out all of our stuff on YouTube and the podcast and all the other things. There's a subscribe button that's going to show up somewhere here on the screen. You all know I don't know where the hell it shows up, even though I'm the one who's editing them. But be sure to like and subscribe. Check out all the other stuff. Ask questions to us down in the comments. And for the Overrun, Ed Bowder and Dan Schwester, once again, we'll talk to you guys next time.
Take care, gang.
Thank you.